Bronchial asthma is a chronic inflammatory disease of the bronchial airway which manifests as recurrent episodes of wheeze, cough, chest tightness, and shortness of breath, which is usually reversible with treatment. It is characterized by increased sensitivity to many environmental agents, and asthma is variable and may be associated with seasons like the rainy season or harmattan. Bronchial asthma occurs at all ages but peak in childhood and is classified as an allergic disease and may be associated with personal or family history of allergic rhinitis as hay fever and eczema or allergic conjunctivitis. Complications of asthma include pneumomediastinum, pneumothorax, subcutaneous emphysema, and pneumonia. So the causes are allergens, for example, house dust mites, cockroach droppings, grass, pollen, and animal hair. Environmental factors, for example, air pollution, climatic changes, strong scents and smoke, including cigarette smoke and car fumes, viral infections, exercise, emotions, and hyperventilation. Drugs, for example, aspirin, NSAIDs, that's non-steroidal anti-inflammatory drugs, and beta blockers such as propranolol, and occupational exposure to industrial chemicals, dust, and drug manufacturing. The symptoms are episodic breathlessness, tightness of the chest, cough, coughing nocturnal, wheeze, nocturnal symptoms. Any of the above symptoms waking up the patient at night. So the signs that are usually elicited are tachypnea, that's fast breathing, use of accessory muscles of respiration, neck or abdominal muscles, bronchi or wheeze, and signs of severe attack, inability to complete full sentences in one breath, rapid pulse, more than 11, that's 110 beats per minute in adults and in adolescents, or more than 130 beats per minute in children 2 to 5 years. Also, rapid respiration, more than 30 breaths per minute in adults and adolescents, or more than 50 breaths per minute in children 2 to 5 years. A peak flow rate is reduced as less than 50% of expected for age, sex, and height. The signs of a life-threatening attack are cyanosis, pulses, paradoxus, silent chest auscultation, drowsiness or confusion, exhaustion, and peak expiratory flow rate less than 33% of expected value, and SpO2 less than 92% of room air. So investigations, no investigation required in most cases. FBC as mildly high eosinophil count, chest X-ray only for the exclusion of other diagnoses or complications. Spirometry as reduction in FEV1 and FEV1 FVC ratio with reversibility demonstrated after a bronchodilator use, as a normal spirometry between attacks does not exclude asthma, and tests for atopy as skin prick and test for specific immunoglobulin E for common allergens, and stool examination to exclude helminthitis. Okay. So the main treatment objectives are to relieve bronchospasm to prevent complications and recurrence, to treat underlying inflammation or infection. Non-pharmacological treatments, avoid known triggers or allergens such as dust, mites where possible, avoid smoking, education on asthma and self-management, device use and technique. So for pharmacological treatment, in acute exacerbation of asthma, and as in initial management in the community, you give salbutamol inhaler using pressurized metered dose inhaler as PMDI with a spacer. In adults and children, give 1 to 2 puffs via a spacer and mask if needed. For example, volumatic or aerotimber or large plastic mineral water bottle, with the patient taking 3 to 4 breaths after each puff. Repeat after every 15 to 30 minutes with a maximum 10 doses. If there's no movement, seek care at a health facility with a nebulizer. Acute, moderate, or severe exacerbation of asthma. Initial management in the hospital. For first-line treatment, oxygen by nasal prongs, 2 to 6 liters per minute, or face masks, 4 to 8 liters per minute, or non-rebreather mask, 10 to 15 liters per minute. And also salbutamol nebulized in adults, 2.5 to 5 milligrams, repeated initially after 15 to 30 minutes, and then every 2 to 4 hours until improved. And in children, 2.5 to 5 milligrams every 2 to 4 hours until improved. And then we give ipratropium bromide nebulized in the adults, 500 micrograms 4 to 6 hourly. In children 6 to 12 years, 250 micrograms 4 to 6 hours. That's 4 to 6 hourly. In 1 to 5 years, 1 to 5 micrograms 4 to 6 hourly. The maximum dosage for children, 1 milligram 12 hourly. And also you give hydrocortisone IV in adults, 200 milligrams start and then 100 milligrams 6 hourly until clinical improvement. In children 12 to 18 years, give 100 milligrams 6 to 8 hourly. 1 month to 12 years, 2 to 4 milligrams per kilogram 8 hourly. And then acute, moderate, or severe exacerbation of asthma, maintenance treatment in hospital. Give salbutamol nebulized in adults, 2.5 to 5 milligrams, repeated every 6 hours until improved. And in children, 2.5 to 5 milligrams every 6 hours until improved. And then ipratropium bromide nebulized in adults, 500 micrograms 4 to 6 hourly. In children 6 to 12 years, you give 250 micrograms 4 to 6 hourly. And then in 1 to 5 years, you give 125 micrograms 4 to 6 hourly. A maximum dosage for children, 1 milligrams per 24 hours. For children less than 12 years with severe symptoms, consider ipratropium bromide, 250 micrograms, repeated every 20 to 30 minutes for the first 2 hours, and then 4 to 6 hourly as necessary. Then you can give prednisolone oral, the initial dose given on admission and subsequently given as a morning dose. Once on prednisolone, stop IV hydrocortisone after 24 hours. In adults, 30 to 40 milligrams daily for 7 days until stable, and taper off dose over a period of 2 weeks if patient has been on long-term steroids. In children, give 1 to 2 milligrams per kilogram for 3 to 5 days. Acute, moderate, or severe exacerbation of asthma, maintenance treatment in hospital where patient is still distressed after 3 to 4 initial doses of nebulized salbutamol. We give aminophylline IV in adults, 250 milligrams slow injection over 2 minutes, and repeat after 30 minutes with a continuous infusion by perfuser if necessary at a rate not exceeding 0.5 milligrams per kilogram per hour over 24 hours, or aminophylline IV infusion 250 milligrams in 500 milliliters of 5% dextrose or 0.9% sodium chloride 6 hourly for 24 hours. And in children, 5 milligrams per kilogram over 20 minutes as a slow infusion or by perfuser at 1 milligram per kilogram per hour, the maximum dosage of 500 milligrams. For chronic asthma, initial management is salbutamol inhaled in adults and children, 100 micrograms, 2 puffs as often as needed. And if inhaled salbutamol is needed more than once daily, we give budesonide inhaled in adults, 200 micrograms, 1 puff 12 hourly. In children more than 10 years, give 200 micrograms, 1 puff 12 hourly. Less than 10 years, give 100 micrograms, 1 puff 12 hourly. Or you can give fluticasone inhaled MDI in adults, 125 to 250 micrograms, 2 puffs 12 hourly. In children, 50 micrograms, 2 puffs 12 hourly. Or you can give beclomethasone inhaled. So for beclomethasone, you in adults and children give 100 micrograms, 2 puffs 12 hourly. For chronic asthma, as maintenance treatment, you give salbutamol inhaled in adults and children, 100 micrograms, 2 puffs as often as needed. And fluticasone or salmeterol inhaled in adults and children over 5 years, give 150 to 20 up to 250 micrograms. So you could either give you could give 150 to 250 micrograms of fluticasone salmeterol inhaled, that's 1 puff 12 hourly. Or you can give budesonide for meterol inhaled as a combination in adults, 164.5 micrograms, 1 to 2 puffs 12 hourly. In children over 5 years, 84.5 micrograms, 1 to 2 puffs 12 hourly. And then you give montelukast. So montelukast oral in adults, 10 milligrams daily. In children, 4 or 5 milligrams granules daily. And then prednisolone oral in adults, 30 to 40 milligrams daily, and tailed down slowly over 2 to 3 week period to a low maintenance daily dose of 5 milligrams daily. In children, 1 milligram per kilogram tailed off by 5 milligrams every third day, reducing to 5 to 10 milligrams daily, or alternate daily, with the lowest dose possible without provoking attacks. Review treatments every 3 to 6 months with a view of stepping down treatment if client is symptom free or has minimal symptoms less than 1 to 2 times a month. All patients with chronic asthma should receive continuous education and counseling by the medical team. Referral criteria. So, in acute exacerbation, refer patients if not improving or rapidly deteriorating after initial management to a specialist. All discharge clients should be followed up within 1 week and referred to a specialist clinic for continued care. For chronic asthma, refer patients with persistent symptoms to have a specialist clinic in a regional or tertiary hospital, and patients who have recurrent acute exacerbations within a few weeks or weeks of each other for specialist care and review of their treatment. Also refer when a patient requires more than one course of oral prednisolone in 3 months.